that this is beyond their personal ability. They just have to accept that this is a valid experience of their ADHD loved one.
They're not just being dramatic.
And also that it's not a weakness. These people are perfectly good, strong people and just suddenly be almost non-functional.
Emotional dysregulation. It's a big part of living with ADHD that doesn't always get the attention it deserves. Some people even argue that it should be part of the diagnostic criteria. So why is this such a common experience? And what does it mean for those navigating ADHD every day? Dr. William Dodson joins me to unpack the emotional side of ADHD, from dysregulation to the nuances of rejection sensitivity dysphoria. In the first of this two-part series, we'll talk about why this piece of neurodivergence is so often misunderstood and what really helps ADHDers manage these intense emotions. That's all coming up on episode 256. I'm Emily Kircher-Morris, and this is the Neurodiversity Podcast.
What is neurodiversity? You see the world differently.
Autism spectrum.
Gifted.
Complexities that are inherently inside.
ADHD.
Dysgraphia.
Tourette's.
All brains are different.
You are exactly what this world needs.
This is the
Neurodiversity
Podcast.
I work with educators all the time, and the stories I hear about supporting their neurodivergent learners are sometimes empowering and sometimes heartbreaking. I know that the teachers, administrators, counselors, social workers, and everyone else out there working with students want the same thing, for the students they support to be successful and happy. But sometimes the way our educational system is set up, neurodivergent kids, whether they're autistic, ADHD, dyslexic, twice exceptional, or some other flavor of neurodivergent, sometimes they're falling through the cracks and teachers don't always know how to support them. You've heard me talk about the new book I wrote with my friend Amanda Morin, Neurodiversity Affirming Schools, Transforming Practices So All Students Feel Accepted and Supported. It was released last week, and now Amanda and I are opening the doors to the Neurodiversity University Educator Hub for a limited time. The Educator Hub is a community of like-minded folks who are working to support neurodivergent young people in the ways that work with their brains instead of against them. In addition to monthly webinars, roundtables, and office hours that we hold for our members, we also create and release resources that you can share with your entire school community to help build awareness and understanding of neurodiversity affirming practices. The doors will open on Friday, January 31st, and are only going to be open for a short amount of time. Head on over to neurodiversity.university and click on the Educator Hub tab to learn more and get registered. You can also look for a link in the show notes. The first part of my conversation with Dr. Bill Dodson is up next.
previously on the Neurodiversity Podcast.
I always like to start any conversation about motivation with awareness that may not be what is really going on. And a lot of times parents will say, he's just not motivated, she's just not motivated. A lot of times our kids really secretly are, but they don't know how to do whatever it is, or they have executive function delays. And so they're having a hard time doing the things that even they want to be able to do.
Yes. There's understanding what's really going on. And then there's how do you help rally and instigate and enroll kids in their own motivation. They are always motivated. It's that something else has them more motivated.
That's episode 249. Find it wherever you get your podcasts.
Today, I'm speaking with Dr. Bill Dodson, a board-certified adult psychiatrist who has specialized in working with ADHD adults for the last 27 years. In recognition of his clinical contributions to the field of ADHD, he was actually named a Life Fellow of the American Psychiatric Association in 2012. Dr. Dodson's groundbreaking work has really shaped how ADHD is understood and treated, and he also introduced the concept of rejection sensitivity dysphoria, along with its treatment options. He also proposed one of the very first strengths-based, non-behavioral theories of ADHD, which focuses on what goes right for individuals rather than solely on the challenges. So, Bill, thank you so much for talking to me today.
It's a pleasure to be here. Thank you for inviting me.
I'm super excited to chat with you, and the main topic that we're going to dig into today is rejection sensitivity dysphoria, but I want to actually start off our conversation by asking about something that is a frequent topic of conversation among clinicians who support ADHD individuals and is related to rejection sensitivity dysphoria, but specifically I'm talking about emotional regulation or emotional dysregulation. So I know anytime I'm working with clinicians who support ADHD people or I'm working with my own ADHD clients, it really seems like that emotional dysregulation appears to be a key aspect or experience of ADHD, to the point that some people would even suggest that it should be part of the diagnostic criteria. However, officially, of course, that's not true.
Well, it is true in the rest of the world. It's just not true in the United States.
Well, tell me more. I'm so curious about this.
We've had the same completely outdated and antiquated diagnostic criteria for 50 years. And they've only been validated for people between the ages of 6 and 12. So our diagnostic criteria do not apply to anybody who's late adolescent or older. And so we've been waiting around for those criteria to be updated, and waited and waited and waited. And finally, in Europe, they just got sick and tired of waiting on the Americans. And so 10 years ago, they issued guidelines on the diagnosis and treatment of adults. And they have also now done a 10-year update. And in the 10-year update, they said we definitely need to add core criteria because the ones we have are all behaviorally based. And they're written for researchers, not for people like you and me. And the big one they added was emotional dysregulation. And again, I have to put a fancified name on it. And that, what they really mean is that people with ADHD lead very intense and passionate emotional lives. Their highs are higher, the lows are lower, to the point where from time to time it becomes impairing. So what they're really talking about with emotional dysregulation is control of emotions. And so that is the fourth core criteria everywhere else except the United States. In the United States, they just can't get their act together.
I mean, is it just the process of how they identify what these signs are when they release each new edition of the DSM? Like, is there a specific type of pushback that's going on with that? What's holding that back?
Well, a lot of the researchers in the field of ADHD got their PhDs back in the 70s and 80s when behavioral psychology was all there was. I mean, it just completely dominated the field, and so they still think entirely in behavioral terms, not in emotional terms or anything like that. And so they're just very rigid in their thinking. There's a presentation to do about the 6 questions that we should have been asking all along but didn't. Number 1 is, look back over the last 25 years. Can you think of anything new in the field of ADHD that actually worked? Nobody can.
Mm-mm.
The field's paralyzed right now because a lot of the people in charge are just very rigid thinkers.
Mm-hmm.
And so adding something about emotions, they just can't wrap their minds around it, and they oppose it. And unfortunately, they control a lot of what's published.
Interesting.
So
some systemic barriers.
Yes, very, very systemic barriers.
Yeah.
And so what they're finding is the world, and also people just practice ADHD medicine and their patients, have moved on without them.
It's fascinating because I was diagnosed with ADHD in 1991, whially at the time, especially for girls,
was just way out there.
Yeah, but my mom was a special ed teacher and she was very resourceful. But yeah, I mean, when I look back now, it's like, you're right. There really hasn't been any evolution since then on how those are identified. I mean, we changed the name a little bit, but that's about just barely.
And you talk about something that's been completely ignored, and that is women with ADHD.
Mm-hmm.
Because their presentation is totally different from males.
Yeah. Let's dive in and talk more specifically about rejection sensitivity dysphoria, or RSD, which we'll use either of those terms interchangeably, but that is a term that really resonates deeply with a lot of people who have ADHD diagnoses. But as you've mentioned, kind of like with the emotional dysregulation, this has not been embraced by the research community. What is RSD? What are the key features that really define rejection sensitivity dysphoria?
RSD is actually a sort of a subset within the whole notion of emotional dysregulation. The problem with the emotional dysregulation concept is that every diagnosis we have has as part of it difficulty with regulating emotions. So it's what they call trans-diagnostic. You find it in everything. Therefore, it is specific and diagnostic of nothing. So it's been very difficult to actually apply that as a diagnostic criteria for ADHD, because whatever you say about it could be said about every other diagnosis. Rejection sensitivity dysphoria is exactly the opposite. It's very specific, 12 criteria that people, like 95% of people, have all 12. And it's based on what I was hearing from patients for years and years and years. In fact, I spent 10 years listening to people, trying to catalog what I was hearing and stuff like that before I ever spoke or wrote about it, trying to figure it out. But what I found was that when I was working with someone, after about a year or so, maybe a little more, people would trust me enough to tell me about the fact that they had episodes that hit them suddenly that were extremely emotionally and physically painful. And if they told no one about it, their spouses didn't know about it because they were deeply embarrassed by not being able to control themselves. They were very afraid of being thought of as a head case, is usually the term people used, because they couldn't control their emotions, or being thought of as being immature or incompetent. And so it was sort of this feedback loop. They were sensitive to criticism and rejection. If they told anybody about it, they would be rejected and criticized again. And it just, was on a downward spiral. So I put together 12 features that I heard from just about everybody. The first 5, which are there in everybody, are basically to separate it from all the mood disorders, because these are drastic, tremendous swings in mood. And so mood disorders, by definition, have broken free from the person's life, the events of their lives. In other words, there's no trigger. They have a very slow onset over weeks or months. They stick around by definition longer than 2 weeks, usually it's about a year, and then there's a very gradual offset. With rejection sensitivity dysphoria, exactly the opposite. It is always triggered. Now, other people may not see the trigger, but if you ask the person, can you remember a mood shift that was not triggered? And they go, no, I can always see the trigger.
Yeah.
And what's more, the mood that I have matches my perception of the trigger. So when bad things happen, I feel bad. When good things happen, I feel good. Again, which is not a mood disorder.
Right.
The onset is instantaneous. 0 to being in a pit in the blink of an eye. Rarely do they last more than a couple of hours. Usually people say I go to sleep and wake up fine the next morning. So the very fast onset doesn't persist 2 weeks. So in every way, it is different from a mood disorder. You can separate this from the mood disorders with great confidence. The other thing that I usually emphasize is that these moods are normal moods in every way except their tremendous intensity. Now, nobody likes to be rejected, criticized. Nobody likes to fail in front of people. But for people with ADHD, it is much worse. In fact, the word dysphoria is literally Greek for unbearable. So while everybody has these experiences, for people with ADHD, they are just an order of magnitude worse. And that's something that their neurotypical family and friends really struggle to understand because they don't have a personal experience that matches up. They don't know what it's like to be just completely bowled over and overwhelmed suddenly out of the blue, without any warning, to just be in a pit of despair. And so that's one of the first things that a person has to do is they have to help the people around them understand just how unbearable their experience is, and the fact that their significant others are just going to have to accept that this is beyond their personal ability. They just have to accept that this is a valid experience of their ADHD loved one.
They're not just being dramatic.
Not being drama queens or something.
Yeah.
And also that it's not a weakness. These people are perfectly good, strong people and just suddenly be almost non-functional. They have to really sort of separate themselves and pull themselves out. The next 7 are basically features that are kind of unique to RSD. One is that the severe pain that they feel, emotional pain, is also physical.
Mm-hmm.
People talk about having just a thump in the chest or feel like they're being stabbed or their guts are on the floor. I mean, it's a physical pain as well as an emotional one. That if they internalize this sudden emotional experience, for all the world, it looks and feels like a full major depressive episode. Severe emotional pain, inability to feel pleasure, inability to feel connectedness to other people. They feel as if they've been cast out, rejected from the whole rest of the world.
Mm-hmm.
If it's externalized, it is usually in the form of a rage at the person or situation that wounded them so severely, an emotional and physical wound. That's another feature of RSD is that people struggle to have any words to describe the feeling. It's overwhelmingly intense, but they can't find words for it. The only thing they can really describe usually is its intensity. It's overwhelming, it's catastrophic, but they have a real hard time describing the quality of the emotion, which is very frustrating and also very puzzling to therapists and clinicians. Because the person say, I just feel bad, I feel bad, I feel bad. They can't give it any further description.
Yeah, our favorite thing as clinicians is to say, well, tell me what the emotion word is.
Right. This is also not a dissociation. When they do feel separated from the world, dissociations are supposed to be something that protects us and neutralizes overwhelming emotions. And this withdrawal is part of the pain. It doesn't diminish it at all. So it's not a dissociation, which a lot of people want to write it off to as, this is some sort of flashback or something like that, which people do not describe. In my experience, once an episode has started, it has to run its course. So the treatment is prevention, because these are really, really painful experiences. Now, it also has a very profound effect upon the development of a person's personality. These hurt so bad, they are so disruptive to life that they become vigilant for anything that might trigger it. So some people try to become perfectionists, to be above reproach, which of course is a trap because you have to keep doing it because people do not applaud yesterday's performance. And so they're constantly performing, trying to be above any criticism at all. The most frequent one, however, is they become people pleasers. They get good at it, too. Somebody new walks into the room, within seconds, they can tell you what sorts of things that person will approve of and praise, and that's what they give them. To the point where many people completely lose track of what they want for their lives. They're so busy making sure that everybody else is happy with them. About in the mid-40s, I go, wait a minute, when is it my turn? When do I get any gratification out of my own life? And of course, the people they live with want to keep things the same because they kind of enjoy having every need met before they're even aware they have it. So it's a tough dynamic to break.
That's so fascinating to think about how that all ties in together and that domino effect of how one thing kind of leads into the other. Okay, so we've established already that the emotional dysregulation is, outside the U.S., a key component of the ADHD experience. Is RSD something that is most often seen or not necessarily, like it's kind of just a subset within the ADHD population?
It's extremely common. We're talking about at least 95% of people with ADHD have impairing rejection sensitivity. For about a third of my patients, it was the most impairing part of their ADHD. They had found ways around their academic and work performance, but they couldn't find their way around this one. Of course, like everything in life, there's a bell-shaped curve where there's some people on one end of the curve where it's just not an issue, and some people where it just controls their lives. One of the other adaptations to it is basically to give up. That just the whole notion of being that severely wounded on a daily basis they stop trying to do anything. And so these are the slackers of the world. Now, people may have, a college degree or something like that, but live in their parents' basement. They've never applied for a job, never asked somebody on a date, because just the imagination that somebody would say no is so daunting that they've basically just given up. Unfortunately, these are the people we don't see because they don't come out of the basement.
They don't ask for help because they don't even, it's so terrifying and so overwhelming.
Or just coming in to talk to a doctor they do not know and that they anticipate doesn't understand at all what they're going through. They've never heard of rejection sensitivity dysphoria. I think quite rightfully so. They're not expecting a good, understanding, empathic response.
Yeah.
So this is a whole population. We have no idea how big it is, but I literally have hundreds of patients who fit this description.
Yeah.
Who are usually brought in by their parents because their lives are going nowhere. These are wasted lives, primarily because of rejection sensitivity.
I'm curious. I know in the neurodiversity community, especially online, there are a lot of people who really resonate with this idea of rejection sensitivity. Outside of the ADHD population, I think specifically in the autistic community, a lot of people talk about this. And I'm curious, is it anybody who experiences some of this emotional dysregulation might also experience RSD? Or is it maybe like autistic people might also have a high likelihood of being ADHD? And so then that's where that's coming from? Or is this something that makes sense and so they're calling it that, but maybe it's something a little bit different?
I wish I knew.
Yeah.
I have no idea. One, I am not a researcher at all.
Yeah.
I'm a practitioner. I saw patients for 45 years. So I don't know.
Yeah.
I'd love to know. We just closed a study that we're doing on our own dime with a couple of people actually around the world, chief investigators in Connecticut, but there are people in Turkey and Hungary and all that who are contributing to it, asking these questions. Is this universal among people with ADHD? We don't know.
Mm-hmm.
Is it something that everybody has to some extent, or who does and who doesn't? We don't know.
Mm-hmm.
Again, because we can't get the people who do research to have any interest in it at all.
Yeah.
Anything that we've done and published, we've done on our own dime.
Yeah. You mentioned specifically about like the dissociation, which is commonly associated with like a trauma response. It sounds like what you're really describing is part of the ADHD experience, regardless of previous life experiences. I think a lot of people sometimes talk about the fact that like childhood experiences maybe are a contributing factor. And you talked about that with the personality piece, about how kind of there's the domino effect with these things, but also because ADHD kids are so much more likely to be reprimanded and disciplined and critiqued for their behaviors. And they may struggle to build strong friendships because of all of the different factors that are influenced by the ADHD. The early life experiences that may have led to some sort of internalized trauma based on those experiences is really separate from the rejection sensitivity dysphoria.
Yeah. I think of them as additional. There's nothing in the world that cannot be made much worse by having an extremely unhappy and abusive childhood.
Mm-hmm.
Michael Jelenick's article that by the time a kid's in the third grade, they have heard 20,000 additional negative or corrective messages in school alone.
Yeah.
This doesn't count what they hear at home on Cub Scouts and all this other stuff. There's another very good piece of research by a guy named Nakama from Japan that at the same age, third grade, 70% of kids with ADHD do not have a single friend.
Mm-hmm.
And so, yes, people with ADHD, and those are the people I know, rejection is a part of their lives.
Mm-hmm.
Criticism is a part of their lives. But the thing is, I see RSD in people who had perfectly delightful childhoods.
Mm-hmm.
So it's, to me, people who have these awful, critical, unhelpful teachers, parents, just have that much more to deal with.
Right.
Also, again, being a practitioner, I'm always thinking about what can I do about this?
Right.
For disorders, conditions in the Diagnostic and Statistical Manual that come from our experiences. They come from what has happened to us, and that anybody who experienced this type of traumatic experience, it would leave a scar. Those things don't respond to medication worth a hoot. They respond to what we call somatic therapies, like EMDR is particularly good. They also respond to cognitive therapies like DBT. DBT is much better than cognitive behavioral therapy, but both are helpful. So trauma-based events that happen to us, we haven't really found any medications that do much good. And some, like the benzodiazepines, actually make PTSD worse. So for the trauma piece, I want to make sure that somebody gets some EMDR as quickly as possible. And, of course, all the preparatory trauma-based psychotherapy that goes with that. For somebody that has something that's based in their genetics, ADHD is clearly inheritable. When you find somebody with ADHD, at least one parent is going to have ADHD, and half of their first-degree relatives are going to have ADHD. So, to some extent, ADHD is going to be their norm. So, things which are genetic, neurologically based, physiologically based, the first step is always to, as best you can, level the neurologic playing field with medications. I sort of divide things into three different camps. If somebody comes in and one of their big problems is just emotional dysregulation, they have difficulty controlling their emotional lives, and they have ADHD, first thing I'm going to do is try a stimulant. Because I know that if I really fine-tune that medication so that all they get is benefits and no side effects, 2 out of 3 of those people are going to be essentially symptom-free with just the stimulant medication. They're tremendously effective. Research has not looked at that. There are only like 4 or 5 out there that specifically looked at that, but all of them record remarkable, almost curative effects of medications. Next group are the people who do have rejection sensitivity dysphoria, and while stimulants are noticeably helpful, they're not nearly adequate. And so for those people, the response is twofold. One is see if they're going to respond to the alpha agonist medications, guanfacine and clonidine, which are FDA approved for the treatment of ADHD. Still staying on the ranch here, and not venturing too far away. But again, somewhere around 2/3 of people are going to have a remarkably positive response. People describe it as putting on emotional armor. They still see the slings and arrows of outrageous fortune that were there last week, but now they sort of fly past and they aren't wounded by it. But that usually is still not sufficient. And so doing a lot of balancing of their lives so that they are more prepared to handle their emotional lives. So trying CBT and especially DBT to change some of the thinking and unhealthy, unhelpful responses or anticipations is a good place to start. But then just leading a life in balance. The big thing is getting enough sleep. Most people with ADHD are chronically sleep deprived. And we all know that when we're sleep deprived, we are not at our best. We're irritable, we're impulsive. It's ugly.
That's the truth.
Getting a good balanced nutrition. And for a lot of people with ADHD, just remembering to eat. People with ADHD just suddenly become aware that they're ravenously hungry. They're a little foggy in the head. They're jittery. And it's because they forgot to eat all day. So just, establishing a structured time in which to have a couple of calories. I have been tremendously impressed with the importance of drinking water. Dehydration. The first thing I do when somebody's in one of these states is offer a glass of water.
Yeah.
It's almost immediately effective. And also just helping the person do the work of balancing their emotional lives. This is where I tell people who say, well, I don't take the medication when I need it. Well, you need it.
You need it.
All the time.
You need it.
It's called life.
Yeah.
Episodes of rejection sensitivity don't say, well, at 9 o'clock tomorrow morning, I'm going to knock you to your knees, so be prepared. That
Right.
it comes out of the blue, and by the time you actually take the medication and it's in you, usually the episode is over.
Yeah.
And then also have a supportive, understanding group of people around you, people who are not going to criticize you, who are not going to treat you as in some way less or ridicule you for periodically being out on the ledge, but understand that this is an affliction that person did not ask for, does not want, is doing their best to control, and they just need their help. Certainly don't need any criticism. It's a lot of work for people with ADHD to accept they have to work every day to keep their lives in balance. You have to do what it takes.
And it's one of those pieces that is always so difficult for ADHD people because it doesn't come automatically. That structure and that routine is something that kind of flies in the face of what their automatic response is. But it shows that having that is one of the best proactive things if you can build those into place and try to be proactive about it.
And a lot of that is accepting that as a person with ADHD, or just, it's the whole definition of neurodiversity, my neurology is different from the majority. I'm not even sure it's a majority. I think it's just a plurality.
Sure.
Because there are a lot of different nervous systems out there. And our big mistake has always been to assume that everybody was the same.
Part 2 of my conversation with Dr. Bill Dodson is coming your way next week, where we continue to dig into what we know and what we don't know about rejection sensitivity dysphoria. Be sure that you are subscribed on your favorite podcast app and add it to your download list so you don't miss it. I'm Emily Kircher-Morris. I'll see you next time on the Neurodiversity Podcast.
Thanks again to William Dodson. If you'd like to know more about him, find a link to his work in the show notes. Also, pretty much anything you want to know about the podcast is probably on our website, including all 256 episodes, some swag, and various other things. It's at neurodiversitypodcast.com. Our host is Emily Kircher-Morris. Corey Orrick is our office manager and production assistant. I'm the executive producer, Dave Morris. For all of us, thanks for listening, and we'll see you next time. This is a service of the Neurodiversity Alliance.